In the series of Learn Simply Academy Vaginal Surgery Masterclass, topic is operative vaginal delivery. That's a safe forceps and vacuum assisted techniques. In this series, in this chapter, or you can say the course roadmap will be choosing between the forceps and vacuum, prerequisites and safety checklist, application techniques step by step, and recognizing and managing failure, and maternal and neonatal complications. Now, why this matters? A core skill in decline. Nowadays, people are not using the forceps and vacuums less and less, and the patients are ending up more into the cesarean section. The 3 to 5% of the vaginal delivery worldwide use forceps or vacuum. It's a decreasing trend. Operative delivery skills are declining across the training programs. A well-timed, well-executed operative delivery can avoid unnecessary cesarean sections. Now, decision-making indications for the operative delivery are prolonged or arrested second stage of labor, suspected fetal compromise, maternal exhaustion or a contraindication to pushing are the indications. Safety prerequisites checklist is fully dilated cervix, membranes ruptured, head engaged, position and station confirmed, adequate anesthesia and empty bladder. The operator should be skilled one, and there should be a backup plan available whenever we are doing these deliveries. Then decision making, forceps versus vacuum, whom to choose, when to choose, why to choose. Forceps, higher success rate, more maternal soft tissue trauma, better after coming head and face presentation. Vacuum, less maternal trauma, but more neonatal scalp trauma, 𝗡𝗏𝗏, and easier to learn, faster to apply. Anatomy and a classification by station. Outlet forceps or outlet is a head at perineum, sagittal tutors at the anteroposterior. Low, that's a leading edge at the station plus 2 centimeter or lower, and mid is the head engaged above the station plus 2 centimeter. Now, safety. These are the contraindications: unengaged fetal head or uncertain position, suspected fetal bone determination disorder, true mid pelvis or high station, face or brow presentation or vacuum. Technique, forceps application. These are the key steps. Number one, you confirm the position, station and pelvic adequacy. Apply left blade, then the right blade. Gently lock the blades and should lock without any force. Traction with contraction and with the along the pelvic. Confirming the correct placement. Sagittal sutures midline between the blades. Posterior frontally, one finger above the plane. Fenestration barely admits a fingertip on each side. Then in vacuum application, key steps are: place cup over the flexion point, 3 centimeter anterior to the posterior frontally. Check the maternal tissue trap under the cup plate. Raise the pressure gradually, traction with contractions, and track descent with each pull, stop if none. Safety rule, there should be 3 pull rule. 3 pulls without adequate descent, abandon that. 20 minutes, maximum total application time should not exceed the 20 minutes. These limits exist to prevent the fetal and maternal injury from prolonged attack. Decision making, recognizing a failed attempt. There is no descent with correctly applied traction. Cup detaches, pops off more than twice. Delivery not imminent within the set limit time. Then managing a failed attempt, stop and reassess. Do not persist. Sequential instrument use, resist trauma risk. Move to cesarean delivery without delay. Complications, anticipating shoulder dystocia, higher risk after any operative vaginal delivery. Have your maneuver sequence ready before delivery of the head. Call for help early. Do not wait for it to develop. Maternal complications, perineal and vaginal lacerations include oasis, postpartum hemorrhage, and urinary retention or injury. These are the neonatal complications with forceps, facial nerve palsy, usually transient, skull or facial marks from blade pressure. Rare is the skull fracture and intracranial hemorrhage. Complications with vacuum, scalp abrasion, trigonal expected resolves. Cephalhematoma more common than the forceps. Rare but subgaleal hemorrhage, watch closely. Subgaleal hemorrhage, red flags, diffuse, fluctuant scalp swelling, crossing the suture lines. Rising baseline heart rate following hematocrit, a rare but life-threatening emergency, act fast. Documentations are essential. Indication, station, position before application, number of pulls, total time of application, findings on maternal and neonatal exam after delivery. Practice, anesthesia consideration, adequate analgesia is prerequisite, not optional. Pudendal block if epidural spinal not in place. Reassess adequacy before applying the instrument. Practice, the trial of operative delivery. Consider a trial in a theatre when success is uncertain. Full cesarean setup ready before attempting, especially for mid-station or the borderline cases. Success rates, what the data shows, 90% overall success rate for outlet and low forceps delivery, 75 to 85% success rate with a vacuum-assisted delivery. Recovery, postpartum follow-up, examine for occult sphincter injury before discharge, counsel and expected healing and warning signs, plan a structured pelvic floor follow-up visit. Training, education and simulation. Simulation builds competition before real access. Structured mentorship shortens the learning curve. Skills decline without regular case exposure. Counseling to the patient. Explain why operative delivery is being recommended. Discuss the alternatives of cesarean and its own risk. Obtain informed consent whenever time permits. Clinical judgment, pearls and fit pawns. Pearls are correct diagnosis of position matters, then instrument choice. Treatment should mimic uterine contraction, not force. Stop early if anything feels wrong. Attempting delivery with an unengaged edge. Exceeding pull time limits, just one more try, and skipping the postpartum sphincter examination. So the key takeaways are summary and closing. Confirm every prerequisite before applying any instrument. Vacuum spares maternal tissue. Forceps has higher success. Respect the pull and time limits and abandon early if needed. Always examine for occult sphincter injury before discharge and skill delays or decays without regular exposure.